Hi everyone. Thank you for taking time today to learn about cardiovascular health. It's a topic I'm very passionate about, but one that's applicable to everyone. That's because cardiovascular disease is the leading cause of death in the United States, even in pandemic years. But the good news is that it's very preventable. So that's what we're going to talk about today. What is cardiovascular disease, how it progresses, and what we can do about it. Before we dive in though, I want to let you know this presentation is educational in nature and not intended to diagnose, treat, or mitigate any illness or disease. We'll go over a lot of good information, but if there are changes you want to make to your diet, exercise routine, or supplement choices, please go over them with a qualified healthcare provider. A lot of people already know what the cardiovascular system does, but just to give a brief overview, it's made up of the heart, arteries, veins, and capillaries. Every day, 24 hours a day for the rest of our lives, nonstop, the heart pumps blood through this vast network of vessels, carrying oxygen and nutrients to every tissue in the body. It's easy to see how crucial this system is, both for life and longevity. Cardiovascular disease is a term for a collection of conditions that may impair the functioning of this system. Included are atherosclerosis, heart failure, arrhythmia, and heart valve problems. Atherosclerosis is by far the most common form of cardiovascular disease and the one we're going to focus on today. It's characterized by the accumulation of fatty plaques within the blood vessel walls. It's not really like a pipe like you see in a lot of graphics that just gets clogged up, but it's a process that occurs within the vascular walls and eventually presses inwards where the blood flows. And this can actually block blood flow to anywhere in the body, not just the heart and brain. The way this process begins is through some sort of vascular injury. Our arteries are lined with a thin layer of cells called the endothelium. And when we have long-term chronic issues like high blood pressure, high glucose, or high cholesterol, it can be damaging to these cells. Once we have a site with an injury, our LDL cholesterol, like what we get checked for at the doctor's office, can infiltrate the arterial lining. Once there, it begins to oxidize and break down. Since this is unhealthy for an artery, it starts an inflammatory response. Immune cells are called in to take care of this issue. Monocytes evolve into macrophages and start to take in this oxidized cholesterol. They eventually form foam cells, and that's what makes up the bulk of that space in the necrotic core that starts to push out on the arterial lining. To keep this all contained, a fibrous cap is created by our body using muscle cells, proteins, immune cells, and various minerals. If this fibrous cap or calcification is stable, we don't have a lot of problems. But inflammation, both from the insults outside the cap to the necrotic core on the inside, can weaken it. Most of the time when someone has a heart attack or stroke, it's not because the arterial wall eventually closed off. It's because there's a rupture in this cap. The lipid core spills out into the bloodstream, attracts platelets, and we can have blood clots. This can block blood flow to anywhere in the body. But the heart and brain are most significant because that's where we get heart attacks and strokes. Often we associate heart attacks and strokes as conditions that older people have. And that's perfectly acceptable until we get old ourselves. It's also not exactly the truth because the fatty streaks in arteries actually start when we're very young. In fact, 50% of American youth already have these early indicators of cardiovascular disease. By the time we get to be 21 to 39, 85% of us are going to have these early indications. And what that means, it's not a matter of whether or not we get cardiovascular disease, it's when and how bad is it going to be. The same things that are creating these conditions in older people are what's to blame for younger people getting it as well. Caloric excess, hypertension, hyperglycemia, and dyslipidemia all contribute. We know now that cardiovascular disease, the hardening of the arteries and dysfunction of the vascular system is not something that just naturally occurs as part of the aging process. It's a lifestyle disease brought on by the choices we make about our health. A combination of nutrition, exercise, and stress management can effectively address most modifiable risk factors. In fact, it's estimated that 80% of all cardiovascular disease may be preventable. To put some numbers to that, last year about 655,000 people died from cardiovascular disease. Now, if we had healthy lifestyle interventions, we could have brought that number down to 131,000. The first thing we need to know in preventing cardiovascular disease is how much at risk are we? Well, there are some major risk factors that are applicable to everyone: hypertension, age, diabetes, and family history of premature cardiovascular disease. Because there is a genetic component. But what I always want to let people know is genetics are not a death sentence. Genetics can be overcome with lifestyle interventions, but we have to be more serious. And the indicator we would have here is if we had a father or a grandfather that had cardiovascular disease, a heart attack, or a stroke before age 55. Or if we had a mother or a grandmother have a heart attack or stroke before the age 65. That would give us a good indication that we need to be a little bit more serious because we have a predisposition. Then we come to lifestyle factors. These are the things that greatly contribute to the progression of cardiovascular disease, but we have control over. Smoking, poor diet, physical inactivity, stress, lack of sleep, and excessive alcohol consumption. I'm going to talk most about diet today because it's a very powerful intervention, but we shouldn't underestimate stress in our lives either. Stress has been shown recently to be a risk factor almost on par with hypertension for cardiovascular disease progression. The reason for that is stress isn't just having an emotional effect on us, but it has a physiological effect as well, and this can be very hard on the arteries. So after we've determined whether or not we have a family history, the way we're going to begin to address our risk is by looking at the normal screening targets that you might get at the doctor's office or our annual health screening event in September. The first one that most people look at is total cholesterol. Most recent evidence has shown this is not the best estimate of cardiovascular disease risk, but if you want to put all of your eggs in one basket, an optimal number may be less than 150. And that's pretty low, but that is the point where cardiovascular disease gets increasingly rare. Same goes for LDL. There are some problematic aspects about using that as just a single value for determining risk. But if you have established disease, you've had a heart attack or a stroke, you do want your LDL to be under 70. HDL is on the other side of the coin. It's another one of those proteins that's implicated with cardiovascular disease, but in a positive way. Whereas LDL can get caught in the arterial lining and oxidize, HDL helps prevent that oxidation process and also can pull that LDL back out of the lining. Because of that, we want higher numbers, above 40 for men or above 50 for women. Triglycerides are another kind of blood fat that can be damaging. We want those under 150. And blood pressure, because it is such a significant risk factor, under 120/80 is optimal. Fasting glucose sometimes gets overlooked for cardiovascular disease, but we want it under 100 because people with diabetes are at a much greater risk of developing this condition. For higher risk individuals, there are advanced lipid panels. The first one is C-Reactive Protein, and this is just a generalized test for the amount of inflammation in the body. It could be from anything, including atherosclerosis. So if you have a high number, it doesn't tell you a whole lot other than something's going on, but if your number is low, that can be a good indication that you don't have advanced heart disease because you're not displaying the amount of inflammation that would normally accompany it. There's also LDL particle number in the various subclasses. And you might be thinking, well, we just talked about LDL cholesterol and that's what my doctor checks for. Well, sort of. Your doctor checks for LDL cholesterol, the total, and it's actually a calculation that's made based on your other numbers. But LDL particle numbers is the actual amount of particles. So you can have the same amount of cholesterol packaged in more or less particles, and that usually affects their size. If you think about it, it's like driving on the road. If you assume for a given space there's going to be 24 other people, the amount of cars they're packaged in is going to make a difference on how crowded things feel. If you have 24 people and they're only in 3 vans with 8 people in each van, there's still going to be a lot of space. But if you have 24 people and they all have their own car and they're packed in that freeway area, it's more likely someone's going to get knocked over to the side of the road. Lipoprotein little a is another very interesting particle. It's very similar to an LDL cholesterol particle, except it has a little tail on it. And that makes all the difference. It makes it more likely to infiltrate the arterial lining. It can assist in oxidizing other LDL particles. And if it gets out into the bloodstream, it makes you more likely to develop a clot. This is an independent risk factor. So no matter how everything else is going, this still increases your risk. It's also genetic. There's not a lot that we can do about it with lifestyle. But it's still good to know, because if you have high Lp(a), that means you have to be more aggressive in your other measures. And in fact, it's been shown if your Lp(a) is high, if you reduce your LDL cholesterol even more, you pretty much mitigate the additional risk. But if all of these different particles are kind of confusing, you can also just look at ApoB. If you look back to the diagram, you can see that both of them have this red protein kind of structure on it. And that's because ApoB is on every single atherogenic particle. So an easy way to tell if you have a lot of atherogenic particles is that one number, and you'd rather have it lower than higher. If you don't want to mess with an advanced lipid panel, or if insurance doesn't cover it, you actually still have really good information just in the standard values that you get. So just by using your total cholesterol and your HDL cholesterol, you can better estimate the risk. It's a lot better than just using the total by itself or LDL. So the first way is you can take your total cholesterol and divide it by HDL. You're going to get a number, and you want it to be under 5 for good health. Now, if you don't even want to mess with division, and you just want to keep it super simple as subtraction, you can take your total and then subtract HDL from it. That's going to give you another number, and you'd want that one to be under 130. It might be easy to think that LDL is just this negative particle that our body makes to make our life hard. But that's not true. It's actually very important for health. The reason for that is we need fats in the bloodstream, but they can't just go through by themselves. They don't mix very well with blood, so you just get these big pools of fat going around. Instead, our body is smart enough to package it in proteins that can travel effectively through blood to get to the tissues where it's needed. And with these proteins, the low-density lipoprotein, high-density lipoprotein, we can transport cholesterols, fat, and fat-soluble vitamins throughout the body. So with the fat-soluble vitamins, for instance, vitamin A, vitamin D, E, K, along with CoQ10. These are really important things that we do want. Right there, we're talking about immune regulation, antioxidants, bone support. So without these, we'd be very unhealthy. So we need LDL, we like having it, but we want healthy particles in the right amount that don't stay in our system too long. There are a few different ways that LDL, what would otherwise be healthy, can become problematic. One is if we have too much LDL. So a caloric excess can help drive that, but the main culprits in the diet are going to be eating too much saturated or trans fat. Trans fat is not as big as it used to be since most people have moved away from it, but a lot of saturated fat can still be problematic. So too much butter, cheese, or fatty cuts of meat can drive that LDL higher. But it's not just about watching fat. It's also problematic if the LDL gets too small. Remember, I said that the smaller particles are more likely to infiltrate the arterial lining. And the way we can usually drive the size down in our LDL is to eat a lot of refined carbohydrates like sugar and white flour. And it's also a problem if the LDL is too easily damaged. For the LDL particle to infiltrate the arterial lining and to stay in there, it has to become oxidized. And the way it's going to become oxidized is largely dependent on the types of fat that are incorporated into that particle. All the fats we eat are easily incorporated directly into the tissues of our body. So whatever kinds of fats we eat are going to be more present there. Well, a high intake of omega-6 fatty acids, which are found often in vegetable oils and packaged food, will make that LDL more likely to oxidize. So we want to limit intakes of those kinds of fats as well. And now it's really kind of hard to structure a diet just around specific nutrients. So we want to look at generalized patterns that can help prevent this illness. At the end of the day, if you're eating something that manages a caloric excess while lowering all the risk factors, you're probably good. But you want to be careful. You might feel good because you lost a lot of weight, but then your cholesterol's through the roof. Or you're eating a different kind of diet. You're losing weight, your cholesterol drops to the basement, but your triglycerides are creeping up on you and the glucose. So you want to make sure you're hitting all those, or you might be undermining some of your efforts. There are two dietary patterns that have been shown to be very effective through observational studies for preventing cardiovascular disease. One is the DASH diet, dietary approaches to stop hypertension, and then also Mediterranean-style diets. They're actually very similar to each other and both emphasize vegetables, fruit, whole grains, legumes, nuts and seeds, and moderate amounts of lean protein. The differences are that the DASH diet will have a little bit more low-fat dairy, whereas a Mediterranean-style plan tends to feature olive oil. It shouldn't be surprising then that the basic platform we use for health coaching here at Washburn University is based on similar plans. This is the Employee Wellness Program Wellness Wheel, and it gives you a really easy visual way to structure a plate and get those kind of benefits. The most important thing to notice is that half the plate is fruits and vegetables. Then outside of that, I've put recommendations for the quality of foods to make sure the other side of the plate is on track as well. For people at highest risk though, like if you've had a heart attack or a stroke, it might make sense to think about moving progressively more towards a plant-based diet. The reason these diets get so much attention in this area is because there have been small studies from Drs. Ornish and Esselstyn showing small amounts of atherosclerosis regression. Plaques actually got smaller. It's not a significant amount, but it definitely shows the effect these powerful diets can have. They're very similar to the DASH and Mediterranean plans, but with small adjustments. There's minimal to no animal protein or oils. But compared to a standard diet, there's increased fiber, vitamins, minerals, and protective phytonutrients. They do tend to be rather low in fat though, and without much animal protein, there's the possibility that certain nutrients are going to be low in the diet. Because of that, a multivitamin is often recommended, especially for B12. So why are plant-based diets so helpful for cardiovascular disease? It's pretty much because they're hitting every single one of those targets we're talking about. They're reducing inflammation and stabilizing plaque through all the nutrient density of the foods. Cholesterol tends to lower by quite a bit by the limitation of saturated fat in the diet. Glucose can be balanced with fiber-rich carbohydrates rather than white flour and sugar. They improve blood pressure with minerals and macronutrient ratios that favor vascular function. LDL particles are also protected by eliminating the refined vegetable oils that can increase their oxidation. But the big question is this the only way? There is the possibility that we can make small modifications to these diets and still get most of the benefits. This is especially true for people in the intermediate risk categories. Vegan plans may be challenging to maintain if you're not used to eating that way, and it also might not be optimal for everyone's health. If someone needs a higher calorie diet, fat restriction can be problematic. Also, if someone's athletic and they're training really hard, they might need more animal protein. Fortunately, similar approaches have been used to good effect. Dr. Lance Gould, who did some of the initial work with Dr. Dean Ornish, now runs his own clinic for atherosclerosis treatment, and he allows for the inclusion of egg whites, non-fat dairy, fish, and lean meat in his program. Apparently, he still gets results. Extra virgin olive oil is another fat source that people tend to fall on different sides of the fence on. There's a lot of observational data that shows that it can be part of a protective diet to prevent cardiovascular disease, but there's not as much research on how it affects the vascular function in people who already have the illness. I think there's a good chance that it may be the optimal source of fat for a higher fat plan, but as to whether it's better, worse, or the same compared to the lower fat options, we just don't know yet. After talking a lot about the different risk factors in diet, cholesterol still is important, and cholesterol reduction remains a primary target for risk reduction. If your cholesterol is high and you're in one of those higher risk categories, your doctor's still going to want to bring it down. Now, no matter how healthy we eat, some people are just genetically predisposed to having higher cholesterol. Basically, their bodies don't have as many LDL receptors as other people's to pull that cholesterol out of the bloodstream. Statins are a very effective pharmaceutical intervention for lowering LDL cholesterol. And in fact, if you have heart disease already, it's probably a good idea to be on those. But if you don't need as much support, there are some natural treatments that also support healthy LDL levels with the added benefit of reducing lipoprotein a. Niacin is one of my all-time favorite nutrients. It's tremendously useful for a wide variety of conditions, but it's a powerhouse for heart health. Before we had statins, niacin was the go-to intervention to lower LDL cholesterol, but it also had the added benefit of raising HDL cholesterol. Niacin has since been replaced by statins in medical care due to the efficacy of statins and the reduction in side effects. But unlike statins, niacin can also lower Lp(a). This can still be useful for people even if they're on statin therapy. One of the main reasons, however, that niacin fell out of favor was because it did have a very notable side effect. When you take high doses of niacin, like what people do to control cholesterol, you can get what's called the Niacin Flush. It's this prickly, tingly sensation. It starts at the top of your head and goes down through the rest of your body, turning your skin red. I actually find it very pleasant, but some people can't stand it, and it's a good reason to be on statins if you don't like that effect. Red yeast rice is another popular nutritional supplement that is used to help manage healthy cholesterol levels. This makes sense because it contains monocolin K, which is a natural statin. In fact, this compound is what lovastatin, the drug, is based on. It reduces LDL cholesterol through the same mechanisms, but interestingly enough, it also works on lipoprotein a. We don't quite know why it does this, but it's probably because it doesn't just have monocolin K, but it's got a variety of statin-like compounds that may be exerting that effect. This supplement is a nice alternative to people who have statin sensitivity or individuals that only have moderately high LDL plus lipoprotein a. The one drawback is, unlike statins, this is not a standardized product. We're never quite sure how effective it's going to be, and it's usually not quite as powerful as the higher intensity statins. So it really just depends where you're at on that risk and the level of support you need in determining which one you might want to go with. Antioxidants are another class of nutrients that have gotten a lot of attention when it comes to talking about heart disease. And it makes sense. One of the main problems we have in this process is that oxidation of the LDL particle. If we have antioxidants to help make sure that process doesn't happen, it stands to reason that this is a net benefit. And it's also been shown that vitamin C, vitamin E, carotenoids, polyphenols, and CoQ10 are all associated with a decrease of atherosclerotic risk when found in the diet. Once we move to supplementation, the results become a little more mixed. Some studies show a benefit, others don't. Now, I still think they may be of some value, but the main place they're going to shine in is correcting a deficiency. If you're not getting that RDA level of certain nutrients, then taking a supplement is definitely going to make a difference. But if you already have a great diet, then you're getting the vast majority of those benefits already. And the change in dietary pattern can make a much more profound impact than still maintaining a poor diet and adding supplements to it. So while they may help, stick with food first. In summary, the first thing we want to be aware of is our family history. And after determining if we're genetically susceptible, we can use basic screening parameters to identify additional risks. This will also be the way that we keep up on whether our interventions are working or not. Higher risk individuals may want to request advanced lipid panels. And like I said, this really doesn't change what needs to be done, but it gives us an idea of how intense we need to be. Any number of plans may work for prevention, but the DASH diet or Mediterranean style plans have the most research behind them. For people at higher risk, increasingly plant-based diets may be advisable, though some intelligent modification may be made. And if after all of these lifestyle interventions, if we still need help in reaching some of our preventative targets, we can incorporate some medications or natural therapies. Thank you for taking the time today to learn more about your health. But just because this presentation is ending doesn't mean the support does. By participating in the Employee Wellness Program, you'll have many more opportunities throughout the year to improve your health and wellness. We have the annual health screening, the Lifestyle Concepts for Health and Wellness course, personal health coaching, and employee challenges. If you have any questions or would like more information, please reach out. You can call me, email me, or go through the website. I'm always happy to talk more about health, but thank you very much and have a good day.